Orthopedics, the shoulder. Most problems of the shoulder are related to fractures and rotator cuff problems. Here is an acromial spur. Here's an arm traction for a arthroscopy of the shoulder or subacromial biseectomy. Prep. Dislocated shoulder anterior. Dislocation AC joint here inferior with a fracture. Dislocation superiorly, that's the most common type. Dislocation AC joint, most managed non-operatively, but when it's right up near the ear you may need to operate on it. Dislocated shoulder here, just notice on incidental x-ray, been out for 2 years, a 79-year-old. Stress views of the AC joint can show the dislocation. Dislocation anterior with a fragment. Dislocated anterior shoulder, partial brachial plexus palsy afterwards. Could have been pre-existing, could be post-existing related to traction. The so-called lateral view to discern whether the dislocation is anterior, either coracoid, or posterior, the acromion. Typical posture, dislocated anterior shoulder. There's the auxiliary view determining whether it's anterior or posterior. Bilateral anterior shoulder dislocations in the student, usually with an epileptic fit, easily reduced. Complete dislocation AC joint on the right side. Here, see the step off? Dislocated left AC joint. Luxatio erector, hand above the shoulder. Fixation of a dislocated AC joint, see, screw fixation. Post-repair of a Hill-Sachs lesion in the patient. Posterior shoulder dislocation, don't miss, symmetrical appearance of the humeral head. Typical posterior shoulder dislocation, locked in internal rotation, don't miss it. There's a posterior shoulder dislocation out the back. Posterior shoulder dislocation, symmetrical or ice cream cone appearance of the humerus. Scapular rotation technique, reducing dislocated shoulder, can be used for right sternoclavicular dislocation. Hard to see, need to do CT views to discern it. Voluntary dislocator of the shoulder, watch out for these. Do a reconstruction, they just tear it apart. Voluntary posterior dislocator. Fracture of the distal clavicle often needs open reduction, internal fixation. Fracture of the greater tuberosity, you can leave these. Inferiorly, doesn't involve too much articular surface, you can leave that one. Surgical neck again. Fracture of mid-clavicle child, perfect remodeling, no operation. Mid-glenoid fracture, this will need open reduction, internal fixation. This is a large step-off deformity. Fracture of the neck of the scapula. 4-part fracture of proximal humerus. Often these require surgery as they go on to delayed union, non-union. 4-part fracture of proximal humerus with inferior subluxation. Again, they often require replacement of the proximal humerus. Fracture of the spine of the scapula, unusual. Fracture surgical neck, 24-year-old. Could do open reduction, internal fixation, or a skillful closed reduction. Here's a skillful closed reduction. It left a slight varus, but would have good function. And there it was. It still went on the bony union. 4-part fracture of proximal humerus, non-union the clavicle, 41-year-old. This may require open reduction, internal fixation, bone grafting if it becomes symptomatic. Fracture of the lower an angulated lower glenoid from a previous fracture. Wasn't causing the patient any problems, so it was left. Fracture mid-clavicle, non-union. Gunshot fracture distal clavicle will require bone grafting. Comminuted fracture mid-clavicle did require bone grafting and fixation. There's an open reduction, internal fixation, fracture distal clavicle. There's an open reduction, internal fixation, fracture of the glenoid. There's a fracture of the non-union fixed with reconstructive plate bone graft, went on to union. That's in an adult. Posterior shoulder dislocate locked over the back of the glenoid. Rush pins used for fixing fracture of the neck of the humerus. Ganglion excised from the AC joint, there it is being excised. A healing fracture of the clavicle, remodeling. There's a hemiarthroplasty placement for a fracture of proximal humerus. Infection, osteomyelitis, right sternoclavicular joint. Hard to pick up clinically. Bone scan will show it. So you've got a moth lesion here. Instability, posterior translation in the shoulder. Labral detachment in the shoulder. Here it is at arthroscopy being debrided. Here's a muscle detachment. Deltoid rotator cuff repair, and then the deltoid repair detached from the acromion because a soft bone is a smoker. Pectoralis major avulsion. Pectoralis major avulsion. Often you don't need to repair these. Radial nerve palsy. Winging of the scapula serratus, anterior nerve palsy. OA of the glenoid. Hypertrophic OA of the AC joint. Can be painful, and workers need to surgery. Here it is, hypertrophic OA post sports, post hard work. Shown again. OA of the shoulder, second appendix disease. Unusual to get OA of the shoulder, usually post-traumatic. Major cuff, rotator cuff repair, good, doing well at 2 months. Fracture of the greater tuberosity. Calcification, rotator cuff can be very painful. May need to excise it. Here's a repair at 2 months. There's the old way of putting rotator cuff in. Now I can use bony anchors. Here is periscapular wasting associated rotator cuff pathology. Here's a good rotator cuff repair. This is the end of part 1. Please look out for part 2 of the shoulder.